Good afternoon, everyone. We will be starting shortly. We will, out of an interest of time for our attendees and our panelists, we'll be starting at 2 p.m. Central Time, 3 p.m. Eastern Time promptly. Thank you all for those who have joined us, and we'll get started shortly. I do see the participant numbers climbing, so please give us a few moments. We're just going to wait until 2 p.m. Central Time for everyone to join. Then we'll get started. You're in the right place if you're here for the RAD-PD patient webinar, and we're very much looking forward to sharing information about our registry with you. Good afternoon, everyone. As you might have heard a couple moments ago, you are here for the RAD-PD Registry Patient Webinar. We will be starting right after I finish speaking. We do have a couple of people joining us as our panelists today, and we're very much looking forward to sharing this information with you. We know that you've been very crucial for our ability to do the work that we're doing through our registry, and we're just so very happy and pleased to be able to share everything that we've been working on for the past couple of years with you all. And so I am going to go ahead and briefly introduce myself, and then I will turn it over to one of our lead PIs who is joining us as a panelist today. This is the Registry for the Advancement of Deep Brain Stimulation in Parkinson's Disease patient webinar. It will be a report to patients on insights from a real-world practice registry. I'm Jillian Garcia. I have been working for about the past year and a half as the project manager for the RAD-PD registry, and I'm joined today with my colleague, Martha Ramirez. She's been working as a project coordinator for the same registry. And without further ado, I do want to introduce one of our lead PIs, Dr. Joohi Jimenez-Shahed from Mount Sinai. She will be delivering the presentation and walking us through just some of the wonderful progress we've made. And I think everyone will find it very informative and enjoyable.
Great. Thank you so much, Jillian, for that introduction, and to both you and to Martha and the Neuropoint Alliance for your support in organizing this project behind the scenes. I want to welcome everybody to the webinar. As mentioned, this is a report to patients who have participated in the registry and perhaps some others that have been familiar with or have heard about, or maybe are just interested in the work that we have been doing with this deep brain stimulation registry. And so we're really excited to be able to share some of this information with you so that you can really get a sense of how important and valuable the data that we're gathering from the registry can be to the world of deep brain stimulation and Parkinson's disease. So my name is Joohi Jimenez-Shahed. I am a movement disorder specialist at the Icahn School of Medicine at Mount Sinai in New York City. I am the director of the Deep Brain Stimulation program here, and I have been working on RAD-PD along with my co-investigator, Jim McInerney, who's at Penn State University. He is a neurosurgeon. He and I, and along with our steering committee and a patient advocate, actually, who I will also introduce during the course of this seminar, have, again, like I said, been working for a number of years on this project, and we're just really excited to be here at a time where we can share some of this information with you and to also highlight some of the work that we hope to be able to do in the future. So our agenda for this call this webinar will be to first talk about just what are we doing and why, right? So what's the history of either deep brain stimulation, but also the rationale for creating a deep brain stimulation registry. Then we'll talk briefly about registry design and kind of how we set this up. We'll talk a little bit about the challenges and the successes that we've had in doing this, because it really is sort of one of the first efforts of its kind to really kind of build on this scale. We want to share with you a little bit about what we've learned from the data that we have been able to gather so far. And then lastly, we'd like to talk to you a little bit about the future of RAD-PD. And before I get started into just the slides, I want to remind everyone that if you do have questions, please go ahead and type them in the Q&A panel of the box in Zoom. We will have a moderated session towards the end so that we can hopefully get your questions answered. So please feel free to type those in as we're going through, but we'll give you time at the end as well to type any other questions that you think of. So first, let's go ahead and get started. Let's talk a little bit briefly about deep brain stimulation. I assume most people on this call are very familiar with what DBS is, especially if you have been participating in the RAD-PD registry. If not, we'll just talk very briefly about kind of where we've come with deep brain stimulation and why we felt like it was important to actually put together a registry effort. So DBS kind of, some of you may actually be familiar that we're actually in the 30th anniversary of deep brain stimulation for Parkinson's disease this year. Even though that sort of as a product and as a treatment has really been around for 30 years, some of the work really underlying how DBS came to be started many years before that. And so this dates back, even as far as like 1953. There's other things before that I'm not showing you here, but in 1953 was a very important event that occurred, which is when a surgeon named Dr. Cooper was performing a procedure. There was an incidental kind of unintended effect that affected the parts of the brain that we now actually stimulate in deep brain stimulation. And this inadvertent issue was found to actually reduce tremor. And so we have really been able to capitalize on this event to really understand how the brain functions and then how we can treat neurologic diseases such as Parkinson's disease, targeting this particular part of the brain. Now, many of you may be familiar that in the 1960s and specifically in 1968, levodopa was introduced. And once levodopa became available, this was a huge milestone in the treatment of Parkinson's disease, and really all thoughts about surgery kind of subsided for a while because levodopa was working so well. However, as you all know, treatment with levodopa comes with its complications, and those can be things like dyskinesias, fluctuations, needing to take multiple doses per day. And as a consequence, there then became, again, a renewed interest in trying to understand how we can address some of these issues surgically or even in other ways. And then, kind of all the development of different medications, et cetera, et cetera. So in 1987, there was a first DBS procedure that was actually performed in the thalamus. Then, as I mentioned, about 30 years ago in 1993, the first case of STN DBS was performed in France, and that was highly successful. Following that was the case series that was published of a different brain target called the globus pallidus interna. So those are the 3 brain targets that can be used for the treatment of Parkinson's disease. You have thalamus, STN, and GPI. And this was closely followed then in 1997 by the Food and Drug Administration approval of deep brain stimulation for treatment of tremor. And then subsequently, specifically for Parkinson's disease in those additional targets in 2002. So there's really been this kind of long history about DBS. It's been around for a long time. And now, as I've mentioned, specifically for Parkinson's, at least 30 years in this country, at least 30 years worldwide, but we still have a lot to learn. And I think this is some of the underlying motivation behind the creation of this registry. So as I mentioned, in 1997, DBS was approved for treatment of tremor, actually. And so it could be anybody with a specific type of tremor called essential tremor, or patients with Parkinson's disease tremor. They were receiving deep brain stimulation in the thalamus. That was approved in 1997. For the STN or GPI, which are now kind of the main targets that we use for DBS, that was approved in 2002 for Parkinson's disease. And then this may be a piece that some of you are not familiar with or are less familiar with, was that there was actually a revision to the approval criteria in 2015, where rather than just saying patients who had advanced Parkinson's disease and were dealing with a lot of these complications and had tried all the different kinds of medications, that we can now actually consider using deep brain stimulation in patients who've had Parkinson's for at least 4 years, so much sooner in the disease course than was previously done. With at least 4 months of troublesome motor complications. And so this really kind of opened up the opportunity for us to be able to treat even more patients and to treat them earlier in their disease course. And some of you may have benefited from the application of this revised indication. So that's kind of where we are at the moment in terms of how we can really think about using deep brain stimulation for the treatment of Parkinson's disease. But what do we really know about the efficacy of DBS in Parkinson's and associated outcomes? Well, there have been several randomized controlled trials that have been done over the years. These randomized controlled trials are generally considered the gold standard of clinical evidence. They do show us that deep brain stimulation is better than continuing with medical management. So the more you continue to adjust medications, you can maybe only get so far with patients, but you can really move the needle when you implement deep brain stimulation in that scenario. We know that when we look at different brain targets, and specifically the GPI and the STN target, we can see an equal reduction in motor symptoms. So it does seem like those can both be quite effective for managing that particular part of Parkinson's disease. And when you look a little bit more into the long term, there is obviously some concern about cognitive issues in Parkinson's in general, but from a surgery standpoint, we really don't see any major long-term adverse effects on thinking and memory. The main one that is noted quite consistently is a reduction in verbal fluency, which has to do with how many words and things you can think of with a certain letter. Those are some of the tasks that we use to measure verbal fluency. There's different ways that might manifest in patients, but that seems to be one of the main kind of cognitive adverse effects. And as I mentioned, we know that there's a similar profile between GPI and STN. However, we know that there is a greater chance of medication reduction with STN stimulation. We also know that from the studies that have been performed before, that age does not necessarily need to be a contraindication to doing surgery. And that was for a long time felt to be sort of a common kind of conventional wisdom, but I think there's quite a few patients within that age category who have been included in these clinical trials and have also experienced significant benefits from deep brain stimulation. We also know from these studies that have already been published that DBS improves quality of life. And we also know that the clinical benefits on motor functioning, like movement symptoms, as well as quality of life, can be seen in a population that's treated earlier in the disease. And we also know that the health economics of deep brain stimulation are actually favorable. So we can treat patients more efficiently and effectively from an economic standpoint as well, using deep brain stimulation compared to best medical therapy. Now, that may sound like we have a lot of really good information about deep brain stimulation, and I think that's absolutely true, but there still remains some gaps. And certainly from the perspective of us as clinicians and researchers who are, trying to understand the dynamics of who are good candidates, who are going to do the best with DBS, what, are some of the ways that we should be delivering DBS therapy with the best evidence possible, we do then find that there are a number of different gaps in these specific details. And so I think many of you may have talked to other people who've had deep brain stimulation, and you might know or have noticed that different people will respond differently to deep brain stimulation, and we don't really have a very good understanding of why that variability in response exists. We also still don't have very clear evidence guidance that tells us what methods of patient selection are the best way to get the best outcomes. We have still some work to do in understanding what specific patient or disease characteristics should drive our therapeutic decision-making, meaning, what are some of the key points that are important for the initial decision to go for surgery? What are some important details related to choosing whether a patient should get GPI or STN? What are the best stimulation parameters given a certain set of symptoms, or what are the best ways to do medication adjustments? We still lack good evidence-based reports on how to answer some of these specific questions. Further, if you take that further, when we look at specific treatment practices, like the different ways that we can deliver deep brain stimulation, again, which surgical techniques are better, which programming strategies are better, which medication management strategies are better, we still could use more evidence to help us answer those questions. Some patients may experience stimulation-related side effects, and how do we manage those? We alluded to health economics, and I think a kind of additional piece of that still requires further understanding is what are the most cost-effective treatment practices when it comes to DBS. And as I mentioned in the previous slide, although we know that deep brain stimulation does improve quality of life, we don't really understand what are the things that are most important to determining whether there's a bigger shift in quality of life after DBS compared, in one patient compared to another. And lastly, I think something that we've thought a lot about as we designed this project was trying to get a better handle on how well patients are satisfied about their DBS treatment, and understanding maybe some of the treatment dynamics there to help us figure out what we can do better to make it an overall better experience for our patients. So I alluded to the fact that the randomized control trial tends to be the gold standard of how we generate evidence for clinical care. And these are great. I mean, they definitely have their role. But I think specifically when we try to apply this to all those different questions that I just highlighted in the previous slide, that can be really kind of challenging to design clinical trials or randomized controlled trials that are going to answer each of those questions. You would kind of almost need a specific trial for each of those items. And that would be certainly cost prohibitive and would really lead to a lot of time and energy and patient effort, as well as site effort to collect all the information that would be required. You would need large numbers of subjects. We might have to make decisions about blinding patients to treatment versus not blinding, and that can get tricky. When you do this type of work in a very specific population of patients where they meet certain criteria, it becomes harder to actually apply that information to the general public who might be interested in DBS as a therapy. And a lot of this work has been done at centers like mine and Dr. McInerney's. We're large centers. We do a lot of deep brain stimulation. And although it would be great if all the patients could get care at those types of institutions, that may not necessarily be the case. And so again, it's this issue of whether the data that we are generating can be applied to the broader population. And alongside that particular fact is an estimate that about 40% of deep brain stimulation surgeries are actually performed outside of academic centers. And so that is, great, because that means that there are more patients who will have access to this therapy, but how can we all work together to understand and implement the best practices for this treatment? And the last point here that I think is an important limitation to think about in terms of the current research model is, even if you're not talking about a large randomized clinical trial, there may be series, there may be a single center study that give us a little bit of detail about a certain group of patients treated in a certain way at a certain place. And again, that may not be broadly applicable to those out there who stand to benefit from this therapy. Another thing that we realized, and this was part of our kind of early planning work with RAD-PD, was trying to get a sense of what kind of information is really crucial to follow in patients who are receiving deep brain stimulation. And when we looked across the board at different studies, at different centers and how they track their patients and what kind of information they are, either collecting or keeping track of, we found a lot of variability. And we started looking at collections of data that are proposed for looking at patients with Parkinson's disease. And there's a number of them here that are listed on this slide. I'm not going to go through these in a huge amount of detail. The point is that they really aren't specific to deep brain stimulation, whereas we know that the patients who are candidates for DBS kind of fit a certain profile and have certain characteristics. And we know that the outcomes that we need to be aware of with deep brain stimulation are very particular and may not necessarily be as important for our understanding in a larger or broader Parkinson's disease population. And so we knew that we had our work cut out for us in terms of trying to figure out which are the best ways to collect information about patients who are getting DBS and how they're doing after DBS. And we had to really come up with a list of different measures that we thought were important and that we felt we needed more information about in order to really kind of get that evidence that we need to fill those gaps that I talked about earlier. Another piece of information that we kind of looked at was how were these kinds of efforts being done and how successful were they in other places? And really, at the time that we started this work, which was, you'll see in a couple of slides, that was back in 2015, actually, there really were not other registry efforts. There are a couple of industry-sponsored deep brain stimulation registries. Some of you may also be participating in those. But beyond those specific industry ones, there really are not a whole lot of other registry efforts going on in deep brain stimulation. What I've listed here are a couple of the randomized trials that have been done of deep brain stimulation, multi-center studies. There's one registry that's listed on here, but these show you kind of the distribution of the different numbers of sites, the numbers of patients that they were able to enroll, and the retention that they were able to sustain of patients who are participating in these trials in that long-term data collection. And, registries are long-term data collection efforts. And so we wanted to try to understand exactly how successful these types of things had been in the past, and if there were any particular considerations we needed to have in order to enhance the degree of success in obtaining this long-term information for patients. So what you see here, you've got the authors listed in the first column. The name of the study or the investigation is listed next. I'm not sure if you can see my mouse here, but the PD Surge study was an effort. I believe that one was in the UK. The VA study was actually done here in the United States, but amongst VA centers. The early STIM study was a multi-center European study looking at patients who were earlier in their disease course and led to that, some of the information that led to the change in the label and the indication for DBS. The NSTAP study was done in, I think, the Netherlands. So multiple centers in the Netherlands. And then the PREDISTIM study is in France. And probably is the most comparable to the effort that we are doing here, which is trying to enroll patients over a number of years and follow them for a number of years. Their goal was to collect 700. I think their data collection was, multiple years, probably a decade or so. And at least in one publication, they were able to show 1 year follow-up data in about 300 or 400 patients. So this is extremely valuable. You can see how much that differs compared to the other clinical trials efforts that are listed here on the slide. And really to be able to amass that much information on patients who have had deep brain stimulation, you can see how that could be a very valuable resource and could give us important insights into what's really going on in the real world. So let's move on then to just information specifically about the registry design. So we obviously designed a patient-focused registry. We want patients to enroll in this registry and to help us to submit data and collect data very purposefully. And very systematically. So it was really important for us to think about how to design an effort where we would be able to get the same information about this group of patients who were treated at multiple different centers, but get the same information consistently over time. And that was really with the goal of generating large data sets that would provide us those insights that we're looking for into those treatment patterns and the related outcomes. We also specifically designed this as a quality improvement effort. And what that means is not a randomized controlled trial. This is real world data. We are collecting information about everyday patients who are getting deep brain stimulation therapy. This turns into a form of what we call health services effectiveness research. And really the issue isn't looking to see, how much does one brain target work compared to another brain target, but we're really trying to look at the system as a whole and how do things work and what are the, sort of other impacts on patients that we can see besides just a change in one specific measurement. And as I said, this is focused on measuring and monitoring outcomes in order to secure positive change. And what that really requires is that not only do we collect this information, but we share it back to the participating sites and to the registry participants in order to inform them and to improve care and practices. And so that is definitely one of the activities that we conduct on a regular basis so that everybody is able to benefit from the data that is being generated from this registry effort. Now, that gives us several unique features to our particular registry effort, right? I mean, this is really, in a way, an effort to develop and collect big data on patients with Parkinson's disease who are getting DBS. And in fact, our registry collects over 1,200 data fields. And that, some of those can be broken down and narrowed into one scale or two scales kind of here and there, but that's a lot of data. And that means that we have our work cut out for us in terms of analyzing that data as well. We also ensured in our registry design that participating sites would be able to receive access to their data that they are contributing to collecting on their patients. And so again, what that allows, and which is different from what might be done in a traditional clinical trial, is for the site staff to be able to use that information actively in the care of their patients. And hopefully it's also information that they find useful and important. The other thing that we'll talk about a little bit more in a few slides is patient engagement. And we have always had a patient advocate on our steering committee. And that was really to give us that patient perspective, to help us design some of our key registry questions to make sure that they were answering questions that were also relevant to patients, and to also help us with designing our data elements or choosing our data elements so that they were really the right kinds of data that we would need to get at those important questions that are important for patients. We also have created a structure in which once all the data is collected, there is the opportunity to have access, like a researcher, for example, could apply to a data use and access committee to receive de-identified data to be able to conduct additional analyses, which we think will be very helpful and instrumental in increasing our knowledge about DBS. So we may have our ideas about what we think is important to be able to calculate and to analyze from this data set, but certainly other researchers may have their own, and they could certainly use this infrastructure to answer some of those questions that they find to be important as well. So our overarching goals of this registry were to do the following. We wanted to identify the best practices surrounding DBS therapy, whether that was patient selection, whether it was specifically related to the surgery, whether it had to do with how patients were managed postoperatively. Our second goal is to identify the adverse effects and those determinants, meaning what was predisposing particular individuals to having maybe surgical or perioperative side effects, maybe long-term device-related complications, falls, hospitalizations, or even death. And our third goal was to be able to identify the health economics and disparities related to DBS therapies. And that could be in terms of either the motor outcomes, like how much do the cardinal Parkinson's symptoms get better? It could be related to non-motor outcomes, meaning things like mood and memory and other, impulse control issues or bowel issues, bladder issues, all those different things that we know are also significant contributors to quality of life in patients with Parkinson's disease. And then eventually, once we have enough of a data set, we could use this information to look at treatment costs and some of the health economics research that I mentioned earlier. So those were our broad goals. In order to do that, we selected a number of different data elements, and I've alluded to the number of data points that are being collected per patient through this registry. But we really kind of tried to collect a broad scope of information about patients. So not only just things about who you are and where you're from, where you might be living, things related to insurance, perhaps things that will help us answer some of those questions about which specific patients are getting access to this therapy and what are some of their non-disease related characteristics. We also collect a fair amount of information about what has happened or where kind of at this point in time patients are in terms of their Parkinson's disease history, how their medications are being managed, and obviously the surgical interventions, specifically the DBS that we are looking to study. We have a number of different ways to measure motor function. Some of that is clinician measured, meaning, finger tapping and foot stomping and walking and looking and measuring all of those Parkinson's symptoms. But we also do have some questionnaires related specifically to motor function, like freezing of gait, for example. And that's not really fully addressed in the usual rating scales that we have. So we wanted to make sure that we had a dedicated scale for that kind of a thing. A whole broad swath of non-motor symptoms, ranging all the way from cognitive symptoms to mood, behavior, anxiety, depression, all the autonomic symptoms that you guys are probably quite familiar with. And then a number of different quality of life scales that will aid with that health economics analysis. And then lastly, adverse effects, whether it's related to the surgery, whether it's related to the equipment, whether it is related to medical complications or even just health complications. And we want to collect this information at multiple time points. So our broad goal is that we would start at baseline when patients are being evaluated for deep brain stimulation surgery. We then want to collect surgical information, and then at 6 months and then yearly for up to 5 years. I think if we collected all of this information in the same way, as much as possible, as completely as possible over a large group of patients, then we would have a very valuable data set to analyze and to really kind of get at those various different questions that I showed to you at the beginning. So we chose to conduct this project through the Parkinson's Study Group. Some of you may be familiar with the PSG. It's the largest not-for-profit scientific network of Parkinson's centers in North America. And you can see the map here of the different sites in the US and Canada. Within this, the majority of members are movement disorder specialists, but also their associated research staff. And within that group, we have something called the Functional Neurosurgical Working Group, which is basically all of the investigators and researchers who are interested in things like deep brain stimulation. And there's over 40 sites, probably many more than that now. This might be a little bit out of date. Since RAD-PD, we've actually been able to add a number of even more sites to this list that are interested in deep brain stimulation and functional neurosurgery. So it's a very broad network of people with common interests, and we chose to conduct this out of their network of sites. You've heard about the Neuropoint Alliance from Jillian and Martha. This is an organization that was established by the neurological surgeons or neurosurgeons with the goal of collecting, analyzing, and reporting nationwide clinical data from neurosurgical practices. And they certainly with us have been working on deep brain stimulation, but they also do collect and help organize and manage registry projects for other neurologic and neurosurgical disease states as well. And of course, they bring to the table their expertise in data and clinical coordination and registry management. So we felt like it was important for us to have a partner with familiarity with this type of research. And from there, we really set about finding our participating sites. And you'll see the list here. Hopefully some of these are familiar to you because you're at those particular institutions getting your care. But we were very fortunate to have a number of different sites that were interested. We conducted careful surveys of sites and were able to select ones that we knew were motivated to collect this kind of data and have the infrastructure with which to do that. And we're very thankful to all of these sites as well as their investigators and research staff for the work that they have done in helping us collect this data through RAD-PD. All right, I want to take a moment to acknowledge our steering committee. So you see myself listed there as a lead PI, Dr. Jim McInerney, who's on the video here as well. You can see is my co-PI, the neurosurgeon that I was mentioning. We have a biostatistician, Arthur Berg. We have another movement disorder specialist, Dr. Mustafa Siddiqui from Wake Forest, who's the chair of our Data Use and Access Committee, Dr. Michelle York, who is a neuropsychologist at Baylor College of Medicine, who is chairing our Safety Monitoring Committee, Dr. Jason Schwab, who is a surgeon at Henry Ford Hospital, who is the chair of our scientific review committee, and you've met Jillian and Martha. But lastly, and importantly, I do want to acknowledge Jim Kirk, who is our patient advocate. He is a patient with Parkinson's and a DBS recipient, so really has been very instrumental in guiding us in a number of different ways throughout the years that we've been working on this project. So we're very thankful for his involvement as well. So our vision was to create this large cohort of comprehensively characterized patients who've undergone surgery and followed for 5 years. We really took some time to engage multiple different stakeholders, whether it was neurologists, neurosurgeons, neuropsychologists, patient advocates, industry representatives, to try to get the perspective on what things were important and how this type of effort could be useful to all of those different groups. We talked about the quality improvement design and how that could be helpful in providing insights and helping practitioners to actually implement those best practices and insights related to getting the best outcomes from DBS. We have the opportunity here within this registry to also link data to Medicare data sets. So for those participants who are Medicare beneficiaries on the consent form for this registry, one option was to consent to the ability to link to those data sets. And so we might gain much more additional informative insight into the care of DBS patients from that linkage. And then lastly, we've given some thought to which are the hypothesis-driven research questions that we could answer using this registry. And I think there's a plethora of them, and we'll share some of those insights with you in a few coming slides. So I think it's important to just take a little bit of stock of the challenges and successes that we've had with RAD-PD. We're very fortunate to be at this point, but that did come with some, kind of ups and downs over the years, as with any project of this size and scope. So we did start back in 2015, as I mentioned, with just some ideas being tossed around. We were eventually able to secure support from the Michael J. Fox Foundation for a project planning grant, which we were then able to get reviewed and approved. And our actual project launch occurred in October of 2018 with our first site that was activated and our first patient that was enrolled in March of 2019. So you can see the number of years that it takes to kind of get an effort like this going and to really get it started. So we were, again, very fortunate along the way to have the support of our different partners and our funders, and certainly the interest of sites as well as patients in contributing to this registry effort. We did find that there were certain challenges along the way, and that in part contributes to the amount of time that it took us to get up and running off the ground, and then also to just sort of the continued data collection once we did start. There were certainly some challenges in terms of site activation. There were issues related to data ownership that we had to resolve and data sharing. Certainly had to navigate multiple different IRBs and just IT concerns related to how we were capturing some of this data. I think from a subject enrollment standpoint, we had to face the reality of the real world pace of preoperative evaluations and surgical scheduling. And although our goal was to have very streamlined data collection, I think patients stand in line for their DBS surgeries, and the surgeries happen when they happen, and the data gets collected when those things happen. So that was something that we learned a lot about as well. And we do have an informed consent process, so we acknowledge that that may have limited some of the subject enrollment as well. Data completeness has been an important part of our data collection effort. And so we really had to work carefully with sites in terms of identifying workflows that would work well for them to collect this data consistently. And that was a very one-on-one process, but we were able to successfully accomplish that. We had a lot of concerns about the amount of data that we were capturing, and we certainly share that concern and want to do the work that needs to be done to really trim that down to make it a more efficient process. And certainly there are ongoing sort of challenges with patient retention that we need to continue to navigate. And one real concern in that regard is ensuring that we have sufficient patient diversity represented amongst our population so that it can be broadly applicable. Now, as you know, since 2015, a few other things have happened in the world. One big one was COVID-19, which hit right when we were trying to get into the swing of things with data collection. And that occurred very close on the heels of some data platform redesign issues that we needed to do. So there were some very real delays there that we had to navigate. And so that I think also created some challenges with how easily some of the data could be collected. And I think, we acknowledged those issues and certainly did our best to navigate them as well as we could. So despite all these different challenges, I think we were pretty successful. So what you'll see here is our actual final patient enrollment for this initial pilot cohort. Although we had 318 subjects who signed informed consent, because of those various challenges, what that really translates to is a little over 200 patients with baseline complete data sets, over 170 patients with complete surgery data sets, 88 patients with 6-month data sets, 48 with 12-month data, and 6 patients with 24-month data. And what I think is really sort of unique and very, kind of nice about this data set is that we, as I mentioned, were really trying our best to encourage sites to get complete data on all of these subjects. And so for the patients, for example, where we have 6-month data, we also have complete data sets for their information at surgery and related to their baseline assessments as well. So this means that we can include as much the maximum number of data points for our analyses. And I think that really kind of enhances the ability, our ability to do what we can with the data that has been generated. All right, so what have we learned? I think this is kind of the meat of the discussion. So I'm going to try to relate this information clearly and succinctly. We have been, over the years of the design and implementation of this project, really been fortunate to be able to share our experience across many different platforms at many different meetings with many different professionals. And we've really taken care to not only work with or to try to disseminate this information amongst neurologists who are treating patients with deep brain stimulation, but also neurosurgeons, also neuropsychologists, and also to the patient population at large. And so this is just a representation of some of our early presentations that we made regarding how RAD-PD was designed and implemented. Here's another page you can see again, across different meetings and in different places in the world. And we still have work to do. There are some upcoming posters and presentations that we have at upcoming meetings, and some that we have submitted and are currently under evaluation for acceptance. So we're very proud of the amount of work that we have been able to do with this data and what we have been able to share with others about how well it's working and what we what we intend to do with the information that we have. So I just want to draw out a few highlights for you. This is a poster that was done and presented at the World Parkinson's Congress in 2019. The pictures that you see on the top right here are of our patient advocate, Jim Kirk. He's actually making a platform presentation here on the big screen in front of the entire meeting. We were very proud to be selected for that, and he did a fantastic job in presenting information about RAD-PD. And we also had a poster, and you see him here sharing his information or sharing information about his poster with attendees at the conference. So this poster highlighted patient engagement. And I think what we've already talked about is certainly true in the case of RAD-PD, which is that having a patient advocate has really provided us important insights into really how well we can involve patients, how well we can retain patients. Jim and his colleagues have been really instrumental in helping us select instruments that represent aspects of outcomes that are important to patients. And it was really helpful to hear their viewpoints on this. I mean, we can sit on our side and think of all the different things that we find important, but ultimately we want to make sure that we're addressing things that are important to patients as well. Jim and his colleagues also helped design some of the elements of the patient-facing elements of the registry. And certainly when we get the data and start being able to look at it, has helped us interpret those outcomes from a patient perspective. And I'll share with you some of those things as well in the next couple of slides. This is one of the posters that we recently were able to present, in which we kind of looked at our baseline, a subset of our patients. Obviously, there's more now since we created this particular poster. But really what it allowed us to show is that being able to collect this type of data and this amount of data in a real world setting in patients who are getting deep brain stimulation for Parkinson's disease is feasible. And that's a very important step for us to be able to share. I think some of our data actually was interesting to look at because it seemed to show that the off time was really one of the main drivers for patients who were going through deep brain stimulation, and probably more so than dyskinesia, which I thought was an interesting point. We found by looking at all the different details that we had captured about these patients that there's a lot of heterogeneity, meaning a lot of different types of people and patients with different sort of manifestations of their disease. And their disease state characteristics, even quality of life, all of these things just really kind of spanned a spectrum. And I think what that allows us to do is to dig deeper into where we can see the greatest successes, where we can see the biggest challenges in terms of DBS outcomes. And so I think it was great to be able to demonstrate that we have that heterogeneity represented. And I think similarly, in terms of the outcomes, we can see that there's a wide range of outcomes, which then allows us to dig in deeper into the whys that is happening and try to formulate, as we said, those best practices and further the information. Similarly, when we looked at the surgical data that was being collected, we found some interesting points. I think obviously being able to collect this amount of information about surgeries is a big endeavor, and we confirmed the feasibility of being able to do that. We found that within our registry, most patients are getting bilateral procedures, most are getting STN implants, and most are having the surgery done awake. However, having said that, there is a variety of either surgical equipment or surgical techniques that are being used across the registry, even at individual sites where we'll see sometimes that sites are doing things differently in different patients. Another thing that we were able to show is that there's a low complication rate, and most patients are being able to go home quite quickly after the surgery, not having to go through other sort of extended rehabs or other treatments. And so that confirms some of the information that we already know about DBS. Now, more kind of getting into the weeds of data analysis is a recent or a poster that we'll be presenting very soon at the American Academy of Neurology meeting in Boston coming up in a few weeks. Here, what we tried to do was to look at all the patients who are enrolled in the registry and try to understand if we can find groupings of patients. And this is important because if we look for patients who have similar characteristics and they kind of cluster in one group or another, you can see here on the bottom left a couple of the different ways that we can kind of represent that data. That starts giving us groupings of individuals to look at and to categorize and to follow and to see how they do compared to different patients. So I think it gives us two pieces of information. One is what's really the kind of situation of patients with Parkinson's who are thinking about doing deep brain stimulation. And then secondly, looking at these subgrouping of patients, how are some of these patients similar? How are some of they different? And how are their effects from DBS either similar or different? And so what we were able to see here with these analyses are that it looks like there's, even though we commonly talk about doing deep brain stimulation for treatment of motor symptoms of Parkinson's disease, we know that quality of life and non-motor symptoms are actually very prominent features, and they're closely linked to each other. And we can actually use those together to try to classify patients into different, what we call phenotypes. Interestingly, we found that non-motor symptoms, as well as impulsivity and impulse control issues, were playing an important role in this phenotypic characterization. And we really think that as we collect more data going on, that we can use that to derive novel outcome measures that really help us to understand what kind of benefits patients can get from DBS and how much benefit they can get from DBS. That also helps us with modeling so that we can sit back and say, if there's a patient in our office who's interested in DBS, if you have X, Y, or Z characteristics, then we can predict these types of changes. And that's, kind of a big goal of the project. Obviously, it's going to take a lot more data than what we have right now, but these are some of the beginning clues as to what types of information we can glean from this. This was a poster or an abstract that we submitted to the World Parkinson's Congress that's upcoming in Barcelona. So if any of you are attending that meeting, please make sure to stop by Jim Kirk's poster, because he will be talking about evidence-based correlates and predictors of medication reduction after DBS. And I think this is an example of an insight that we got from just looking at data. And it was actually Jim who pointed out to us that he was quite surprised to see the degree of levodopa reduction that patients were able to gain after deep brain stimulation. And so we thought, okay, that sounds very interesting. If it's interesting to Jim, it's interesting to us. So let's look at that a little bit more closely. And so what we found here, and you'll see this if you go to the poster, is that a majority of patients were able to reduce their levodopa equivalents. That's what LEDD stands for. 6 months after DBS, 31% were able to reduce their medications more than 75%. So I think that's much higher than the number that is generally tossed around about this. There were a small proportion of patients who increased meds, and that in and of itself is an interesting group to look at, which we probably will do in the future at some point. We know that the particular symptoms of Parkinson's disease, whether somebody was tremor dominant or has the type of Parkinson's that is not associated with tremor, did not really influence how much their medication changes. We didn't really find any predictors, meaning characteristics at baseline before surgery that would tell us this person was going to be able to reduce more or less. But we did see that the amount of levodopa reduction also correlated with improvements in motor and non-motor improvements, but did not necessarily affect quality of life. And so what that means to me is that we can get a lot of benefits out of deep brain stimulation, and the focus on medication reduction may not be necessarily as impactful as some of the other changes that we can see, including improvements in the motor functioning and the non-motor functioning and quality of life. So those were some of the key findings, and I hope that you agree with us that those are interesting things and holds a lot of promise for future analyses. But just to summarize, our real-world experience and real-world data collection confirms that DBS is being performed across a range of patients who have varied features of their disease and varied features of their living situation. And this, I think, provides a rich data set for us to be able to look at. We can show from all of this data collection that large-scale comprehensive data collection is feasible, and we definitely intend to use quality efforts to refine these collection points, like all these different data fields, to make sure that we are collecting the things that are most important. And ultimately, with all of this big data, we're going to be able to do multiple analyses that are really not going to be feasible through standard clinical trials methodology. And we're really excited about the opportunity to be able to continue that. So what does the future hold for RAD-PD? Well, our future plans are really kind of multiple, right? I mean, we hope to accomplish many of these. We have existing data, as I showed you, and those numbers of patients, and we can use that information to really apply for ongoing funding. And so those analyses are happening. As I mentioned, there's a data use and access committee that will be able to field requests for de-identified data to continue this type of data mining effort. And I think we have already been approached by a few researchers who are interested in using the RAD-PD infrastructure for their collaborative efforts and research that they're interested in. And so we think that we have a valuable tool for this type of work. We do want to expand our data set. I think we have had conversations with both DBS and Parkinson's disease stakeholders to see how we can best do that. I think something that would be really great if we can accomplish it is to add a genetics or biorepository. We know the increasing role of understanding these types of aspects of Parkinson's disease help us just to understand the long-term trajectories better. And we would like to incorporate that into our understanding of DBS and DBS outcomes. And of course, we want to be able to fill those evidence gaps. And right now with the data that we have, I think we have some good information that can give us insights into best practices, into adverse effects, into health economics, and even into comparative effectiveness research. And these are, again, some of the things that we want to be able to accomplish. So we're very grateful for the opportunity to be at that point and to be able to look forward to how we can accomplish these different things. And so with that, I want to thank you for your attention, but I also want to very specifically thank our patients who have participated in RAD-PD. Obviously, without you and answering all those questionnaires, we wouldn't have any of this data to try to answer some of these questions. And I definitely want to give a shout out to Jim Kirk for his support and his efforts on this project. We want to thank our clinical sites, the investigators, the coordinators who all of you have worked with. We want to thank our registry partners, the Neuropoint Alliance and the Parkinson Study Group, and obviously to our funders, the Michael J. Fox Foundation, for their support of this pilot period. Our deepest gratitude to all of you. And with that, I will conclude, and we have time for a few questions.
So you actually already answered the first question, and I did answer this directly in the Q&A section, but I just did want to reiterate, someone had asked if can a non-site access any of this data? And so as a part of the pilot phase of the registry, we will make the de-identified data that was collected eventually available to researchers, and that'll be by submitting an application to our data use and access committee, and we'll be sending out a call for applications soon. So keep your eyes out. I posted the link to our website where you will be able to find that information. And then there is one question that I thought would be best answered live. So the attendee asks, they heard the medication reduction of 75% and assumed that was an STN. What about GPI?
Yeah, no, that's an important question. So thank you for asking that. So the 75% was just across the board. And yes, there were a mixture of STN and GPI patients there. I think in the group where we had that follow-up data, it's actually there were not as many GPI patients represented within that group. So the vast majority of that does relate to STN. And I don't think we can be more specific just yet in terms of the differences between STN and GPI medication reduction right now. We'll need more data to be able to answer that more specifically.
And are there any additional questions among attendees? So this attendee is asking if slides will be available. We have recorded the presentation, and the plan would be to circulate that. I know not everyone would be able to view this presentation, and so we hope to make it available.
If anybody else has any questions, we're happy to take them. Please take a moment to type them in the Q&A.
I do have our patient advocate, Jim Kirk, raising his hand. So I was going to welcome you now, Jim, if you want to unmute yourself.
Thank you, Jillian. I just wanted to point out with respect to the question about the medication reduction, the reduction of greater than 75% was for about a third of the patients. About 15% of the patients increased, which if you do the math, that leaves a little more than half of the patients in between zero change and greater than a 75% reduction. So those would be people with a 50% or a 25% reduction. So I don't want anyone to walk away thinking that we're saying that on average, patients reduce 75%. I think the average was something closer to 35 or 40%.
Mm-hmm. Which is what all of the clinical trials seem to suggest as well, with especially with STN stimulation. So yeah, you're absolutely right, Jim. Thank you for pointing that out and for clarifying. And I think what that underlies is, again, this heterogeneity that we see, right? So, being able to say, given an individual patient's characteristics, how much medication we think they might be able to reduce. Those are potentially some of the things that we can start looking into when we have sufficient amounts of data. But you're right, it was a proportion of the patients who reduced that much.
Mm-hmm.
This is a question about the future of the registry. And so the attendee asks if RAD-PD is still looking for DBS patients, or is it closed at this point?
Yeah, no, that's a good question. So right now we had funding for a pilot period to sort of develop our infrastructure and to really prove that this is something that we could do and that we could get good information from. And so that pilot period has concluded. So current data collection is also paused. We are hoping in the near future to be able to start back up again. And once we're able to do that, absolutely, we'll be looking for more patients to enroll. And we'd be very pleased to have anybody who's going through the DBS process be a participant in future registry efforts. Jim, I think, maybe raised his hand again. Go ahead, Jim.
I just would like to point out that when you say, Dr. Jimenez-Shahed, that we wanted to prove that we could do this. I think it's important to point out to all the patients who participated in this registry so far that using patients to collect their own data, to report their own data, is not necessarily an easy thing to do, nor something that is that common. So we really appreciate all of the patients responding to the questionnaires and sticking with it and generating the data from which we can, with which we can do all this analysis. So I think it's important to point out that you have proven something to the world about the reliability of patient data, patient-generated data.
Absolutely, Jim. I think that's also a great point. So we thank you for assisting us in highlighting those aspects of this as well.
And there's another question from an attendee. This person was encouraged to ask, is there a common age limit for DBS therapy?
Yeah, so not really, right? So I think that candidacy for DBS may be based on a number of different factors. And generally speaking, I don't think that age has to be an absolute criteria anymore, but I think we look at sort of the overall, kind of general health of the patient and their disease manifestations to really try to understand if they can benefit from DBS. And so younger patients may benefit, older patients may benefit, but it's more than just an age question. I don't know, Jim McInerney, Dr. McInerney, if you want to add to that, because I think embedded in that sort of discussion has to do with surgical risk.
Sure. And I think, it's fairly commonly understood that surgical risks can go up as patients go up, but we often say it's not so much the age as the mileage. There are old 50-year-olds and there are young 80-year-olds at times, and so I really do think that has to be a decision that's made on a case-by-case basis, and I don't think we've ever felt that there was an upper limit necessarily to age.
Yeah, and I think I'll plug the registry again for the answer to that question, because I think that's certainly something that we can look at and dig into. And there's a huge range of ages. As Jim mentioned, we have younger patients as well as older patients who have gone through the registry process. So we have a lot of information about different groups of ages, and I think can hopefully, again, once we have a lot more data, be able to really dive into those specifics a little bit more about what it is or what it might be about age, and one way or another that may be important to consider.
Thank you. And so I think we're coming close to our time together, but there is one more question I wanted to ask. It's from an attendee, and they were interested in knowing if the posters presented are available anyway that we looked at today.
So we do have the website. So it's radpd.org. Is it? Oh, I can't remember what it is. RAD-PD or no dash?
Correct. Yeah. RAD-PD.org.
Yeah, and so they're not all up there at the moment, but we will be sharing some of that there, especially as some of these newer analyses pass, the presentation mark at the respective meetings where they will be presented. So keep an eye on that website.
Excellent. Well, that brings us to the conclusion of our RAD-PD patient webinar. I want to appreciate the time that all of you have dedicated to our registry over the years and your attention today during our presentation. And we wish you all well and have a good week.
Thank you all.
Thank you.
Thank you.
Thank you.